Hi viewers, hope you are fit and fine. Today we are going our live video online classes from the topic that is Introduction to Midwifery and Obstetrical Nursing, a very important topic from our midwifery that is known as the ectopic pregnancy. Let us start with the introduction. Nowadays, if you see, there is a more increases in ectopic pregnancy, that is fourfold. So the ectopic pregnancy, if you see, it is one of the early bleeding disorder and high risk pregnancy. So this will leads to life threatening situations for the women. When we are going with early identification, prompt treatment with the help of estimation of beta HCG, identification method of laparoscopy. So this ectopic pregnancy complication has come down, like maternal death has come down 80%. But still, due to the infertility treatments, the women having the conditions of pelvic inflammatory diseases, this ectopic pregnancy is nowadays fourfold risk is increased in our country. So let us see what is the meaning of ectopic pregnancy. So normal pregnancy, what do you mean by normal pregnancy? In the normal pregnancy, what happened? The transportation of the gametes, that is the ovum and the sperm, will takes place in the fallopian tube. You know the fallopian tube, no? Fallopian tube, it is 10 centimeter. So fallopian tube, it is interstitial, isthmal, ampulla, infundibular part is there. So here the transportation of the gametes, that is the ovum and the sperm, that will meet in the ampulla part. There only fertilization will take place. After fertilization, this has to be traveled and drop into the uterus, that is upper any lateral aspect of the uterus, and it will be implanted and developed in the endometrium, that is residue of the uterine cavity. So this is the normal pregnancy happen. So the fertilized ovum has to be traveled from the fallopian tube and it has to be implanted and developed into the uterine cavity, that is endometrium of the uterine cavity. Ectopic, what is meant by ectopic? Other than the normal position. So here, if the fertilized ovum implanted and developed outside the normal site of the endometrium of the uterine cavity, then it is known as the ectopic pregnancy. So here we'll see the incidence. Incidence 1 in 250 pregnancies, we can see the ectopic pregnancy. And the women, those who have the history of pelvic inflammatory diseases, contraceptive failures, and they are going with the infertility treatment like ART procedures, embryo transfers. So these women are more risk for getting the ectopic pregnancies. And ectopic pregnancy, main commonest one is 90% we can see the tubal pregnancy. Ectopic not only in tube, other than the site, normal site, anywhere if it is happening, then we can tell as a ectopic. So normal average, if you see, high risk is in the tubal pregnancy. And they can go with the complication of tubal rupture. What happened? Tubal rupture, bleeding, hematocele formations, and shock can be happen. Even the women can go with life-threatening situations like a shock and maternal death can be happen. So this is the main incidence. Next, we'll see what are the sites of ectopic pregnancy. Sites of ectopic pregnancy mainly classified into two sites are there. One is intrauterine site and another one is extrauterine site. Intrauterine site means within the uterine cavity other than the normal implantation and developmental site. So here the uterus, you know, fundal is there, body is there, isthmus, cervix is there. So normally in the fundal part, the implantation will be takes place. If the implantation and development of the fertilized ovum takes place in the cervix, then it is known as the cervical pregnancy. And this also rare condition. Another one is angular pregnancy. If the pregnancy that will happen in the lateral angle of right or left side of the uterine cavity, then it is known as the angular. Even it can go as an interstitial, deeply implanted in the myometrial layer and can have the very complications. Even we have to go with hysterectomy procedure. Another one is corneal pregnancy. So corneal pregnancy, the development and implantation of fertilized ovum or the egg at the rudimentary horn, any one of the rudimentary horn of the bicornate uterus. Bicornate uterus, it is one of the congenital anomaly. So one horn, if any one horn it is developed, then it is known as the corneal pregnancy. Next one is cesarean pregnancy. So previous cesarean women, the previous in the myometrial scar, the development, implantation and development of the fertilized egg that formed is known as the cesarean pregnancy. So you understood, no? There are mainly four: is the cervical pregnancy, angular pregnancy, corneal pregnancy, and another one is cesarean pregnancy. So these are the other than the normal site of intrauterine pregnancy. Next, we will discuss about extrauterine pregnancy. Extrauterine, outside the uterine cavity. So here you can see the commonest one is tubal pregnancy. You know the tube, the length of the tube is 10 centimeter. So any part of the tubal pregnancy, that is interstitial part or ischemial part or ampulla part or infundibular part. So ampulla, if the pregnancy happened, this is the widest 4 to 5 centimeter length is there. So somewhat 8 to 10 week of gestation that can be grown. Further than, very difficult to grow. Another one is infundibular, that is a finger-like projection. Interstitial, that is a connection between the uterine and the tube. Ischemial part, that is between the interstitial and the ampullary part. So anywhere in the tube, the implantation and development of fertilized egg is formed, then it is known as the tubal pregnancy. 95% we can see the tubal pregnancy. Then another ectopic pregnancy is ovarian pregnancy. If the implantation and development of the fertilized egg takes place in the ovary, then it is known as the ovarian pregnancy. That also rare. Another one is abdominal pregnancy. Abdominal, two type is there, primary and secondary. Primary, we cannot define only. Secondary abdominal pregnancy, if any tubal pregnancy, that will go as an abortion or perforation of the tube. If the fetal sac is there, the fetus is live, they can go and move and enter into the intraperitoneal ligament or a peritoneal cavity, broad ligament, and the fetus can be grow. Then it is known as the secondary abdominal pregnancy, secondary peritoneal pregnancy or secondary ligamentary pregnancy. Next, these are the major extra uterine pregnancy. And one more is there, that is heterotopic. Nowadays, heterotopic pregnancy is common. The main incidence is due to the ART procedure, artificial reproductive technology, and embryo transfer. Here, one fetus can be grow in the intrauterine and another fetus can be grow any other side. For an example, like in the tube, then it is known as the heterotopic pregnancy. One in the uterus and another in the other side. So these are the major site of the ectopic pregnancy. Then next we will discuss about tubal pregnancy. So tubal pregnancy, the pregnancy that happen in tube, any part like interstitial, ischemial, ampulla, and fallopian tube. So what is the causes of tubal pregnancy? Main causes is, first we can discuss what are the factors that prevent the transportation of fertilized ovum into the uterine cavity. So which is hindering, which are the factors that prevent? So factors that preventing means, first one is pelvic inflammatory diseases. The women have any PID like chlamydia trachomatis infections, pelvic tuberculosis infections, any sexually transmitted infections. What happened to the tube? In the tube, the cilia will be destroyed. Cilia function. Cilia is very much needed for the movement of the fertilized ovum. That is the zygote. So when the cilia is destroyed, no movement will be there. Then next one is they can go with kinking, telescoping, and narrowing of the tube, and cup-like structures can be formed in the tube. Intratubal adhesions can be formed. So as a result, transportation can be hindered. Then second one is any iatrogenic procedures. Iatrogenic, any induced procedure, like if the woman is kept IUD, intrauterine devices, failure of the intrauterine devices, and using of progesterone only pills, or she underwent any laparoscopic sterilizations procedures. These are the causes that also can prevent the transportation of the fertilized ovum. Next one is previous any induced DNC procedures, and previous any tubal reconstructive surgeries or tubal plastic, and any pelvic tumors is there, tubo-ovarian tumors is there, and if the woman having any tubal congenital anomalies like accessory tubes are there, two tubes are there, so like the different problems the women have, and women having present history of any infertility treatment and artificial reproductive technology, embryo transfers, mainly the SIFT procedure, zygote intrafallopian tube transfer, or gift procedure, gamete intrafallopian tube transfers. So like that conditions, the women can go with preventing the transportation of fertilized ovum from the tube to the uterine cavity. Second factors means what are the factors will helps to nidate or implant the tube in the tubal area. The factors means loss of zona pellucida. You know, ovum is surrounding by the zona pellucida. So early degeneration or destruction of the zona pellucida, this can help in the early implantation in the fallopian tube. Increased decidual reactions and ectopic endometriosis. The endometrium tissues mainly present inside the uterine cavity. If the endometrial tissues present inside the tube, that is known as ectopic tubal endometriosis. So that time also there is more chance for getting implantation, early implantation of the fertilized ovum in the tube. So these are the major factors. Next, we will discuss about what is the pathology. In the pathology, as per the etiological factors, there will be development of the fertilized egg, that is the zygote. From it, what happens? Cleavage, division will be formed, and here growth of the fertilized egg will be formed. And here the trophoblast will be formed, that is the chorionic villi. The villi will be deeply adhered into the tubal mucosa, and this fertilized ovum will be present inside the submucosal or muscle fold of the tubal region. And from the trophoblast, what is secreted? HCG. What is meant by HCG? Human chorionic gonadotrophic hormone. This is essential for the maintenance of pregnancy. This HCG will be stimulating the ovary to form the corpus luteum. Corpus luteum is essential for the production of estrogen and the progesterone. Progesterone is helpful hormone for the maintenance of the pregnancy. So as a result, the fetus will be growing in the tube. But same time, the uterus also will be developed. That is hypertrophy, hyperplasia of the decidia. But in the uterus, no embryo development will be there. It is present in the tube only. Once the tube is growing, as like reaching of 8th week or 10th week, the tube will be stretched, thin out, and no longer the tube will have the space to accommodate the pseudo capsule that formed in the tube. So what happened? Either the tube can go with rupture or the sac can be separated, and this can go as a bleeding. When the sac is separating, the trophoblast will decrease the secretion of HCG hormone. So when the HCG hormone level is decreases, corpus luteum formation also will be atrophy, and estrogen progesterone level will be decreases. Once the progesterone level decreases, the decidia function will not take place. So entire the decidia can be removed from the uterus. Then it is known as the decidual cast. In the tube, what happened? The gestational sac will be removed, and it will be removed from the tube, and the bleeding can be entered through the tube from the abdominal ostia, that is the opening that is present in the fallopian tube, infundibular region. The bleeding can enter into the peritoneum. So this can happen as a pelvic hematosis also can be happen. So this is the major pathology, and the women will have the complaints of pervaginal bleeding and abdominal pain. This we will discuss about what is the clinical manifestation. So clinical manifestation, mainly you can remember like triad symptoms. Triad means what is there? 3 symptoms will be there. First one is amenorrhea. Amenorrhea means absence of menstruation. A short period of amenorrhea will be present. Second one is pain will be there. Pain, that is like abdominal pain. Abdominal pain will be severe, colicky, thrombic abdominal pain if it is rupture of uterine cavity, rupture of tube is there. Then next, the woman will have, if pelvic hematocele is there, any blood collections in the peritoneal cavity. So the woman have the symptoms of So the women have the symptoms of shoulder irritation, hiccup, like that. And following the pain, vaginal bleeding, pelvic pain will be there. Okay. And third one is vaginal bleeding. So this is the main triad symptoms. One is amenorrhea, one is bleeding, and another one is pain. Next, we'll discuss what happened, the fate of tubal pregnancy. Fate means at the end, what happened in the tubal pregnancy. So tubal pregnancy, generally, if you see one, it will form like a tubal mole formations. A tubal mole, a mole is formed on the tube. Sometimes it will be reabsorbed if it is small size and reabsorbed in the tube itself. Another one is it can expelled out like an abortion process. Second one is abortion. That is the separation of the sac and expulsion of the fetus. So here two type is there, complete abortion or incomplete abortions. So complete abortions that can go as a pelvic hematocele, incomplete abortion, diffused intraperitoneal hemorrhage. The next one is tubal perforation. Perforation of the tube, that is happen in the roof of the tube or floor of the tube. If the complete sac is present, they can go with secondary abdominal pregnancy. Then fourth one is tubal rupture, rupture of the tube, a very emergency situation. So the rupture can be go as intraperitoneal bleeding and hematocele formation. Rarely they can go with a continuation of pregnancy. These are the fate of the tube. Tubal malformation, tubal that is abortion, then tubal perforation, tubal rupture. Very rare case continuation of pregnancy. They can go with the tubal rupture only. Next, we'll see what are the diagnostic evaluation. Mainly the clinical signs. Clinical signs finds that symptoms differ according to the nature of the condition. It will be unique from one woman to another woman. When it is, we have to see whether it is an acute case of ruptured or unruptured or chronic. If ruptured is there, continuous vaginal bleeding will be there, severe pain will be there, the women have shock and shock symptoms will be there, syncope, like that features will be there. That is tachycardia, variation of the pulse. Abortions, she can go with hyperthermia, bleeding will be there, abdominal pain will be there. And in the sign, in the abdominal examination, we can find out Cullen sign. So what is meant by Cullen sign? That is a bluish discolorization that is present in the periumbilical region. So what is the reason? Because of pelvic hematocele, that is a blood collections, and abdominal tenderness will be there. So breast symptoms will be decreased. So abdominal will be tenderness. So what happened in vaginal examination? Vaginal examination, bleeding will be there, vaginal tenderness will be there. Well circumcised mass can be find out if it is a chronic ectopic pregnancy. If chronic means they can go with spotting of vaginal bleeding also. So symptoms, it is varied from one condition to another, like acute, ruptured or unruptured, chronic. And if pelvic hematocele is there, pressure symptoms is there. What is meant by pressure symptoms? Urgency of urination, frequency, tenesmus, urgency of rectal, that is emptying the rectum or emptying the bladder. So like that, the women have the pressure symptoms. Next, we'll go with the what are the laboratory investigations. So laboratory investigation, complete blood count. Hemoglobin is very much essential because anytime the woman can go with shock, it is a life-threatening situation. And blood group we have to note out to find to give the blood transfusions, prevent the RH incompatibility. So like that, this thing, erythrocyte sedimentation rate, complete blood count profiles we have to see. Next one is we have to go with procedure like estimation of beta HCG. Beta HCG, that is the human chorionic gonadotrophic hormones. That is we can identify in the blood examination and in the urine examination. So 1500 international unit per ml. So here doubling of HCG will not be present. It will be present, but normal pregnancy doubling will be there, but ectopic pregnancy doubling will not be there. The next one is scanning, transvaginal scanning. In the transvaginal scanning, we can identify in the uterus, no fetus will be present. Okay, and they can compare the transvaginal scan and beta HCG, that is transdiscriminatory zone. By the doctors, they can find out this is the ectopic pregnancy, like that one of the investigation. Next one is they can go with culdosynthesis. Culdosynthesis, aspiration of fluid from the pouch of ductless. So here they can see non-clotting blood can be identified. And next one is progesterone. Progesterone estimation that will be less than 15 nanogram per ml. So that is in the ectopic pregnancy. And DNC, dilatation and curettage, they can identify, they can take the sample and put it in the normal saline bowl of water that doesn't have chorionic villi in the uterus, because uterus doesn't have fetus, no? So like that they can identify. And next one is laparoscopy procedure to note out what is the acute or chronic. If the woman is having severe problem like life-threatening shock symptoms like that, we can go with a laparotomy measures, open and see and find out what is the problem. So these are the main diagnostic evaluation. Next we'll go with the management. Management, main our principal aim is to save the life of the women. So for saving the life, emergency management is there, conservative management is there. First, we'll discuss emergency. Emergency management, when the woman comes with a complaint of like abdominal pain, bleeding or amenorrhea, our aim to rule out whether it is ectopic. Emergency resuscitation measures has to be given to save the woman, along with the laparotomy and all the life-saving measures, anti-shock measures, and stabilization of the woman has to be done. The next one is conservative measures. Conservative measures, the aim one is medical management, is there surgical management. Medical management, we have to see the woman is in stable period, and what is her beta HCG, what is the size of the ectopic fetus, whether it is more than 4 centimeter or less than 4 centimeter. Then we can know if FHR is there. Then we can go with the treatment of medications. Medication like methotrexate, that is salpingetosis, that is anti-cancerous drugs we are giving, no? That is methotrexate, actinomycin, potassium chloride. So like that, drug of choice can be given and they can expel the content. And another one is surgical method. So surgical method, mainly laparoscopic or mini laparotomy method can be used. In the surgical method, according to the tubal pregnancy size, they can see the first one is salpingostomy or salpingotomy. Small incision can be done on the tube and removing the conceptual product. Then second one is salpingectomy, cutting the tube and removing the tube. The next one is segmental resection. That is, identify the tube, cut, and end-to-end anastomosis can be done. And milking the tube. Milking the tube means fimbrial expression of the product of conception. So these are the general surgical measures that can be conducted in the ectopic tubal pregnancy. Next one is our nursing management. As a role of a nurse, what is the main work behind us means we have to assess the woman during the emergency situations, and we have to give all the measures in the resuscitation, and any laparotomy is there, we have to assist the woman in arranging all the articles for the laparotomy procedures and preparing the woman for the laparotomy procedure, giving a counseling for the woman and assessing the woman whether she is going for any shock is there. We have to find out, check the vital signs, temperature, pulse, respirations, any shock measures is there, what is the blood group, whether she after the surgery she need to give rogam injections. So we have to see the records of the physician order. According to that, we can go with the blood transfusions and immunoglobulin therapies, and we can go with the medical treatment methotrexate. And we have to advise the mother to go with the follow-up. Not only methotrexate will be finished, they have to go with follow-up mainly 6 months or to 1 year period, whether their HCG level has decreased or not. And we have to advise the woman not go for conception. So the recurrent ectopic pregnancy also commonest in the women's when they go with conception. So their level of HCG has to be reduced. So that we have to find out. So next, whatever the basic care as per the nurse we can give in order to her restore the fluid electrolyte balance, maintain the comfort, and reduce the risk, and future pregnancies counseling can be given for the women. So today we have discussed about what is meant by ectopic pregnancy, what is the meaning of ectopic pregnancy, what is the incidence, what is the sites, that is intrauterine site, extrauterine site, and what is the pathology of tubal pregnancy, what are the clinical manifestation, fate of tubal pregnancy, what is the diagnostic evaluations, what is the management and nursing management. So hope students, you have had a nice experience of ectopic pregnancy through the online video classes. Thank you. So your conservative comments can be done in your comment box, and we will meet you in another class of online video. Thank you.